Thanks very much for organizing the session and for inviting me. Appreciate it. So as advertised, I'm going to talk a little bit about the return of germline genomic results, including some consensus work that's been going on in the NHGRI and NCI CSER program and the NHGRI eMERGE program. I'll talk a little bit about what are actionable genes, at least by our definition in Seattle, and about the estimated number of these actionable genes that you'll find in whole genomes or whole exomes, and then VUSs, and then the pair to what the consensus was is where we don't have consensus. So the ACMG document that Angela mentioned with the 56 genes that they recommend always be screened for in a genomic test, did raise a lot of controversy, not so much for the list of the 56 genes. They actually had 57 and one got thrown off, but past that, they're down to 56. The genes aren't argued about that much. I could quibble with a couple, I have actually, but I got the 57th one thrown off personally, so I let it go at that. But the mandatory return, first of all, it's mandatory searching because in many lab technologies, we're not looking at the whole genome. We wouldn't even know there were some of those mutations. If you do a trio test in my pipeline, where you're comparing the parent's genomes to a child's genome to look for new mutations, I would never get the results from BRCA1 and 2 at all unless there was a mutation there that was new in the child. The only thing that comes out of the other end of that pipeline that I see is what variants occur in the child that do not occur in one of the parents. So they're asking for something that doesn't have to happen in a clinical lab, which is for you to look at everything and annotate everything and find out what it does. Is it a mutation? Is it not a mutation? These are not that simple of questions. And so people have said, well, gee, maybe we should be doing this in research. We have whole genomes, we have whole exomes, probably have more on the research side than we have on the clinical side right now. And so this group from the ACMG came together, from the eMERGE and CSER came together, and these were the writing authors. But in addition to these authors who really spent a lot of time working on the document, the eMERGE and CSER Return of Results Committee, each consortium has a Return of Results Committee. The CSER one is like 50 people, so it's a big group of people. And then eMERGE also has the CERC Committee, which is their Community Education and Engagement Committee. And so those committees then worked with the final document to come up with a consensus that will hopefully be submitted in the next week or so. Okay, so I've done a little editing here to get things on slides. It's all longer than that, and the more people who looked at it, the more words got added. So I'm trying to pare it back down a little. So these are the principles, and then we go to like what our guidelines are. So the first principle is that research is not clinical work. It's not a clinical activity. It has different reasons. It has different procedures. Therefore, what you do in a clinical setting does not have to be the same as what you do in a research setting. The second principle was that the resources in research are for research. So to take those resources and use them for things that are not research is something that you have to think long and hard about before you mandate that. And that touches on this duty to search issue that we'll come back to. The next is that you should have research assessing a whole range of ways to return genomic information because we don't know how to return genomic information. So we don't want to be too strict in what we mandate people to do in research because we need to understand what all the possible options are and which ones work best. So we don't want to say now the best way to do it because we don't know the best way to do it. That analytically and clinically valid information of important and medically actionable should be returned, should be offered to the subject. So should be returned is the wrong statement, should be offered for return. So no mandatory return, it's up to the subjects, the participants to decide what they want. So that's a lot of words, clinically and analytically valid. What does that mean exactly? And what does actionable mean? Those are all things that we probably have a better idea what's clinically and analytically valid than what's actionable maybe. And then participants should be able to refuse these results. As we know from clinic, as Angela said, many families come in and they say like, oh, my sister's at 50% risk and she's in total denial. She just won't deal with it. Well, that's her right. So we're constantly saying to families, well, let your sister be in denial if your sister wants to be in denial. So we know that people who are at high risk for a genetic mutation can decide they don't want that information. So certainly people who are at low risk for a mutation should be able to decide that they don't want that information. And then we had some language about consenting that I abbreviated. Okay, so what was the process? The process was that we came together with this group of principals first, and then a very small writing committee wrote out recommendations that aligned with those principles, and then we rolled them out to like another 4 people and another 4 people, another 4 people, and we had iterative drafts. Once we had a full draft, we presented it at one of the, at a meeting, at an eMERGE meeting. And we also sent it out to the like 70 people who are on these committees, and we got comments back from everyone, which were incorporated. There were some definite tweaks at the end, which were interesting. So this is where we're at now, and as I said, everyone's seen it, so hopefully this won't change. So there was a strong consensus that at a minimum, researchers should return actionable results, high penetrance, important medical results that they have stumbled on or found in their research on purpose. That there was not a duty to go hunting for genomic results to return, but that if you had something and you had an identifiable subject, you should offer that information back. And obviously it should have been a part of the upfront consent process that the subject knew this might happen. And for some of us who have studies that are 20 and 30 years old, we've gone back actually and reconsented. I've gone back and reconsented everybody in several studies for, and the letter goes like, I probably won't find anything, but if I did find anything, would you want it? Because I don't want to be in the position of saying, oh, now I have something, do you want it? I think that's a very uncomfortable position to put someone in. So I'd rather say, like, I don't have anything right now, and I may never have anything, but would you want it? Because when I first collected some of these samples, I didn't anticipate the possibility of finding incidental findings that were really medically relevant. So we did not, in our group, come up with a definitive list. For the most part, we don't have a problem with the ACMG list. My list is longer. I have 120 genes on the list. I'll come back to that. The CSER consortium actually put a paper together comparing the lists across the consortium. That is a Berg et al. Paper. I should have put the reference in, but it's findable. But because there's not a single clear list that everyone's agreeing on at the moment, it's important when you set up research to decide ahead of time what is your threshold for return so that you can communicate clearly to the subjects as they enroll what kinds of things that you would return. So if you want to go with the ACMG list, great, but just be clear about what you're going to do. So if you don't have identifiable subjects, then you don't have an obligation to return results. So it's not unethical to have de-identified subjects. So you're just can't get it back. That's the way it is. The same thing, if you are doing a secondary analysis on someone else's data that's not identifiable to you, you don't have an obligation to try and get those results returned. You can certainly communicate to the primary investigators what you found, but if you don't have identifiable information, there's not an obligation to return. And then finally, we decided that the obligation to return should really be for the term of funding, because this is something that's not free. Okay, so what were the second recommendations? The participants should clearly have the option to refuse these results. Both the results that are the primary focus of the study, so if you're doing a breast cancer study and you find a breast cancer mutation, they should be able to say, no, I don't want that. Or if you find an incidental finding, they should be able to say, no, I don't want that. In our study, we have a genomic study for colon cancer. We actually give them their colon cancer results back at a separate visit than their incidental findings. And we ask them several times, including at the incidental finding return visit, do you want these results? And they can say no at any of those times. It really is hard to consent people, I think. There's a lot of conversation this morning about consent, but it's hard for people to understand what they're going to get. We find a lot of variability in what people want, but one of the most concerning things that we found, in my view, which was very small focus groups, is we did a focus group of people who had gotten a genomic or gotten a cancer test positive, so BRCA or colon cancer, and then a separate focus group of people who had had that kind of testing, but there had been no informative result for why they had their family cancer. And the people who got a result didn't want incidental findings anymore. And the people who didn't have any result, they did want incidental findings. So I don't know if that's like, well, I'm done, I have my answer, versus I don't have my answer, or, gee, I just found out that having a genetic test result that's positive is a lot more to think about than I thought. And, you know, I think that when you say to people, what do you want, if they don't have a context to understand what that means, it's very challenging to consent them. So again, there was a very small, those are small focus groups, but it kind of rang true with me. So the consent should be clear. Patients should be able to opt out. There are research studies that the whole point of the study is to study the return of results. Those studies do not have to enroll people who don't want results back. But if you enroll and then change your mind, you obviously get to withdraw, and that ability to opt out should be clear. So obviously research should be non-coercive. Parents of minors have the same right to refuse results as anyone else. There is the little caveat if something is medically important in childhood, because Ellen can explain it better than me, that, you know, sometimes the parent's choice can be trumped when it's in the best interest of the child. We did agree, and this was quite a bit of work, we did agree that adult onset findings that were not known in the family could be offered to the families of pediatric patients. In the case of trio testing, where the parents are being exomed or genomed too, and then the child, if the result is disclosed in a parent, then we didn't think it should be offered for the child. But in the case that the family would have no idea there was an important variant in the family, except from that pediatric sample, we did agree that that could be offered for return. Okay. All right. Importantly, in research, it's justifiable to give everything back. So there's no wrong or right about what to give back. In some settings, if you're studying how do people understand a whole genome, you have to give the whole genome back. So we have kind of the floor being like some bad thing that I know about and I know it's you, and the ceiling being give everything back. It really is important to think about what the benefits and harms are. However, when you decide, the analytic and clinical validity, the test needs to be right. So we did have a split on CLIA. I will say that most of us felt that CLIA was not a requirement. And most of you, I'm sure, know that there's some legal questions about whether CLIA is required to return a research result. There's a research exception in the CLIA law that I've always personally found compelling, but I'm not a lawyer. Barbara Evans wrote a nice, very long article where she said that she thought basically it was legal. I'll let you read the article. Regardless of whether it's legal or not, the question is whether it's ethical. We did have agreement. If it is legal, it's certainly ethical to give back a non-CLIA result. Going forward, you should probably design your studies so that you have clear results to give people. But going backward, I've got 20-year-old samples in my freezer, so I can't fix that. I will say, as a clinical medical geneticist, I've had many patients over the years come from research studies with non-clear results, and they come in and they say, I got this in a research study, and now I need you to be my doctor. And then the care is transferred. It's very clear that we bill their insurance, and then I'm their doctor. So it's been done for a long time. It's not a new model. Okay, so we should be measuring benefits and harms of returning genomic information. And then finally, a lot of research needs to be done. So the final recommendation is a lot of things that need to be studied to go forward with genomic sequencing. So I'm going to transition now, that's my transition slide, and talk about actionable genes and how often you're going to find actionable incidental findings. So this is one definition of actionable, and this is something we could have a whole session on, what's actionable. But we said it has to be clearly a deleterious mutation. There has to be specific evidence-based medical recommendations for the condition. There has to be some expectation of improved health outcome. There has to be some sufficient benefit, so not just, a little tweak in care. This group, my group, is not returning cure status at this time. And we made a list of what we considered highly actionable genes. We had a committee of 23 people, I think, and we unanimously agreed on every gene to include as highly actionable. If we did not unanimously agree, then we did not include it. There was actually only one gene that we didn't agree on one way or another. So we had people of all sorts of different backgrounds, all sorts of areas in genetics, but also ethics and clinicians. genetic counselors, fabulous group, good-looking group too. Got Arno Matulski in here still, 90 years old, still helping us out. Okay, so we have our list, which I'm going to come back to in a minute, but we compared across the CSER network what kind of genes people wanted to return. And I made a slide. These are the ones we disagreed on, so it's not like we disagreed on everything, but I made a slide of what we disagreed on. So this is Baylor, Children's Hospital of Philadelphia, University of North Carolina, and University of Washington. And you can see that they considered, this pharmacogenetic thing actionable at Baylor. None of us did. Malignant hyperthermia, okay, we all agreed on that. Neurofibromatosis, interestingly, the two groups that see the most adults thought it was not actionable. Familial Mediterranean fever, we're the outlier here in saying that's not actionable because you would have symptoms. Factor V Leiden homozygous, there's one group that wouldn't return this. They have a very high risk of clotting. The heterozygotes, none of us would return. And then hemochromatosis, oh, I think we all agreed on hematoma. That's an error. Anyway, so these are all experts. These are all medical geneticists. They all have panels of people, and yet we don't all agree on what's actionable. However, at University of Washington, we do agree on what's actionable, and this was our list. We have 120 genes on our list. Most of them are published in the Dorschner et al. Article in American Journal of Human Genetics a couple months ago. In yellow are the ones that were on the ACMG list, so I think we have all of theirs except that are relevant to adults, because ours is an adult-specific project, except ApoB. And we can argue about that later. And then we have a lot of recessives that they didn't consider for some reason. So that's our list. So what did we do with that list? We went through the exome variant server. So most of you know, exome variant server has 6,500 people's exomes from NHLBI studies. And we went through every single variant in those 6,500 people that was flagged by the Human Genome Mutation Database as potentially pathogenic, and decided whether or not we actually thought it was pathogenic. We had 45 people reviewing variants. We reviewed like 500 variants. 643 variants apparently. And we double reviewed a bunch of them, and we actually had a couple junior reviewers, so we double reviewed all of theirs. But it was a good student learning activity. And then we also looked at new disruptive things that wouldn't have been in the database. So that was what we did. We picked a really high threshold for what we considered pathogenic and likely pathogenic. Some of the things down here, a clinical lab might return as pathogenic in the right context, but for an incidental finding, we thought the criteria had to be pretty strict. We wanted to be right. I will say that some of the likely pathogenic, someone said this earlier, this list may change to definitely pathogenic soon because they're accumulating evidence. So what did we find? So we divided into the European ancestry people. There were 4,300 of those, and African ancestry, 2,203 of those. And then we looked at HGMD. And from those, 600 and some that the HGMD said might be pathogenic, we didn't, we let less than 150 were, about 160. So in Europeans, less than 1%, just less than 1% of the subjects had a definite pathogenic mutation. In Africans, it was less than that. And we think this is just a deficit in the literature. Likely pathogenic, another few percent here and 1% there. These are novel disruptives in genes that it's known that a truncation would cause disease. And it's interesting, there's actually more of them over here. So, although I'm not sure that's significant, but this is evening out because this is, doesn't depend on past literature. So in total, even if you're going to include the likelies, which I'm doing in this context because they may cross over into definite in the future, we've got about 3% for European descent and about 2% for people of African descent. You may, in fact, not return anything but the definite pathogenics up here, or maybe you would also add the disruptives. But these are the caps. This is as high as it's going to go. So it's not that common, but it's not unheard of either. Okay, so variants of uncertain significance. So the ACMG recommendations say you should return things that are definitely pathogenic or expected to be pathogenic based on the known biology of the gene. And so I want to just dig in for a second into that expected to be pathogenic thing and ask you, and I would appreciate the experts in the audience to vote on this, whether this is expected to be pathogenic. So we have a patient who has colon cancer at less than 35 years, a bad colon cancer. They have one parent with some adenomas. They had normal immunohistochemistry. And so they got the usual care clinical test, which is a coloseq, which is 11 genes that are like Lynch syndrome genes, the APC, polyposis genes, P53 mutations. This is P10, that's a typo. So those are the usual players, and they were all normal. So this patient then got an exome, and the exome found this variant. It's a SDHB substitution from a serine to a cysteine. So serines are a really important amino acid for phosphorylation, and cysteine, of course, makes those disulfide bridges that are really important to conformation. So this is not an amino acid you want changed, and this is not an amino acid you would want to change to. So what do we know about this gene? It's associated with paragangliomas and adrenal tumors and a low risk of renal cell carcinoma, but notably not related to colon cancer, which is what our patient is here for. So this has never been seen before. It's not in the exome variant server at all. It's not in any database. So it's a completely novel mutation. We don't know what it does. What we do know is that it seems to be a bad thing. So the Grantham score, which is what amino acid you changed from, is very high. This is a high-risk score for a bad change. The GURP score, which only goes to like 6.2, is evolutionary conservation. So this is something that's extremely conserved at this exact position. Polyphen is close to 1. So this is a bad change by these scores. And we know from the literature that if you change the serine to a phenylalanine or a proline or glutamine or a stop at this exact position, all of those are pathogenic. So gee, it kind of feels like it's an expected pathogenic. But what do you tell the patient? Because they don't have even a relevant cancer for this. So is this returnable or not? And you're going to spend a lot of time on this question. And I might add, this took a lot of time to figure out. The variants that we annotated in general took about 37 minutes each. This one took hours for us to go through and try and feel comfortable with what to do. Okay, so moving on to the end, which is what needs to be what we need consensus on. What is an actionable gene? Do we just go with the ACMG list? Do we want longer lists? Who decides what's actionable? Does each study decide for itself? I don't know. Can you return things that are not actionable? Clearly. Okay, adult onset findings found in children. As I said, we got agreement here, but not everyone agrees. There are people who feel that an adult onset finding should never be returned in a pediatric case. Non-CLIA labs, please see the Barbara Evans article, and I think this is still in dispute. Finally, what is the boundary between clinical care and research? And I didn't talk about this much, but it's a really important question because we find with our CSER project, even though we try very hard, we say like, this is your research visit, this is your clinical visit, this is your clinical doctor, this is your research team, that they're calling the researchers for their clinical questions because they don't really understand the distinction and they seem to know us better because they've seen more of us. So it's very hard. I really liked the model in the old days when they walked in the door with their non-CLIA result, and I sent a CLIA test, and then everyone knew that the research study was over, and I was the doctor, and we were moving forward. But it really, you cannot tell these people enough times what is the boundary between research and clinical. And we have people who call us up about their hospital bills that have nothing to do with our study, and say, why did I get this bill? And we say, well, it has nothing to do with us. So, that really is, I don't know how to, I'd love the patient education people to help me make the subjects understand what is the boundary of my study. So we have a great big team. I really, they do all the work, and then I just get up here and talk about it. So I'll wait for questions after. Thank you.